This meeting is being recorded.
Hi, everyone. Welcome to our second Golden Resource webinar. I wanted to introduce and thank our guest speaker tonight, Miriam Benoff. Many of you may know her for her expertise and warmth, and some of you she may be new to. So just a little background, Miriam Benoff is currently at an outpatient office at Holy Name Medical Center in Paramus and has more than 18 years of experience working with the older geriatric population and is familiar with all aspects of primary care and graciously is speaking at our webinar tonight. So we thank you so much and we are so excited. And towards the end, at around 8:45, we're going to open this forum for a Q&A. So any personal questions you have about anything that's going on for you or your family, you're welcome to ask our guest speaker tonight. Thank you for joining. I'm going to spotlight you, Miriam. So,
okay.
you.
That sounds scary, but okay.
But
Samuel,
how
Yes.
come I have this? The face of Miriam is covered with this bleeding.
I am going to mute everyone just in case there's background noise.
So welcome everybody.
Oh, wait. Sorry. Whoa. 1 second, Miriam. You're muted. Sorry.
I just unmuted. Did that work?
That's good.
Okay. So welcome everybody. I'm very honored to be here. I want to thank JFS for, first of all, a lot that they've done for a lot of my patients. I think very highly of JFS and specifically Sarah Katz for asking me. I do want to first state that nothing I say is going to be comprehensive. There is no topic on which there wouldn't be a lot more to add. Please don't assume that what I'm saying is the end of any particular topic. I'm trying to give some basics, some guidelines, some things I've learned over the years. Obviously, the best care anybody can have is care that's individualized to them. So if you hear things that are interesting to you, the best thing you can do is raise it with your healthcare provider. I also just want to mention that I'm still learning from my patients, from caregivers of my patients. Literally last month, I learned that there is such a thing that you can set over a stove that it will turn off automatically if there's no movement at an hour. I had no idea there was such a thing. So I'm still finding things out. You're going to know things that I don't know. Share information with people because there are always things that all of us could stand to get more information on. Okay, just 2 minutes of background. As Sarah said, I have been working for 18 years as an adult and geriatric nurse practitioner. I began initially as a nurse on an acute care geriatric floor at Hackensack, but I really wanted to have a little bit more of a personal relationship with my patients. And in a hospital setting, you meet new people every shift. So I went back to school, became a nurse practitioner. And since then I've worked in the outpatient setting, which I love. Building relationships mean that you know things about your patients that might not appear always in a chart. And that's also an important thing. I'm not saying that everybody has the luxury of a long-term relationship with a provider, but it is something important to hold on to if you have that option. Okay, so the first 3 topics that I was asked to comment on, healthy aging tips, managing chronic conditions, and preventive healthcare, to me are kind of all intertwined. I had trouble separating them into distinct groups. So I'm going to go through a few things that I think are important for all 3 of those. These are things that can help people age healthfully, things that can help with chronic conditions, and things that can be thought of as part of preventive healthcare. The first thing, and I talk about this to my young patients also, if I had to choose one thing to focus on, it would be the importance of physical activity to all adults, but I would say even more so to older adults. A lot of us are schooled to think of physical activity as a way to lose weight or a way to train for sports. But honestly, there are 1,000,001 benefits to physical activity: stamina, balance, strength, good digestion, mood, cognition, bone health, cardiovascular health. It can make tasks easier. It can make socialization easier. The ability to be physically active really cannot be overestimated. Encouraging movement, even in the house, if we're talking about a more frail older person, just the idea that they would have to get up to get a glass of water, get up to use the bathroom. Sometimes I tell people just to stand up and walk between their living room and their dining room and their kitchen, and to do it a couple of times a day. There's almost no situation where you can't get some physical activity. True story, when I was a little girl, my grandmother was told to walk for osteoporosis, and the weather wasn't good. And she set herself a course through her basement, and she did that course like 20 times a day. So it's doable and it's important. For people who feel that they could use some assistance with it, there is physical therapy. Honestly, almost anybody can qualify for some physical therapy at some point. If I had my wish, all my patients would get physical therapy for the rest of their lives, but nobody's asking me. Physical therapy can teach people strengthening and balance exercises. It can show people how to ambulate or walk more safely. If you have physical therapy in the house for more frail older people, they can also help you troubleshoot in the house safety issues, risks for falls, etc. I'm going to share a story. I can't say who it was because many of you may know her, but one of my patients once said, and it was so brilliant, she said, I always feared using my walker because I felt like I would look like an old lady, but I started to use it. I believe she was volunteering in a school. And she said, people said the opposite. They said, you look so much younger walking with the walker, because with the walker, she walked more steadily and more confidently instead of tentatively and holding on to the wall or to doorposts or whatever. So please, please don't be afraid of canes. Don't be afraid of walkers. And if you use them just temporarily because you have a bad knee or because you're recovering, that's fine too. Preventing falls almost never calls for telling somebody to stay sedentary. If we're worried about falls, the idea usually is to try to get stronger, not to just sit to avoid the fall. I'm not going to say there aren't exceptions. As I said, nothing I say tonight is individualized to anybody. But in general, the last thing I like to recommend or hear is we're worried she might fall, so she's not getting up. And that applies to all of us, even younger people after a procedure or with arthritis. Last but not least, when it comes to physical activity, there are things that are not directly related, but impact. So if you have swelling in your legs and someone has told you it's just a cosmetic issue and not to worry about it, if that swelling is keeping you on the couch because your legs feel so heavy when you get up to walk, then please address that with your provider, because you'll walk more if your legs don't feel as heavy. The same thing with back pain. Back pain affects a lot of us, but if the back pain keeps us from wanting to get up and move to another room or do something with our time, then that's a shame and it should be addressed. People who say to me, I can live with it, it's not so bad. That sounds great, but stoicism isn't good if it means that you're going to end up just sitting for long periods of time. So again, just to sum up, if I had to choose one thing to really focus on with my patients, younger but also older, it would be trying to maintain physical activity. Second of all, I wanted to talk a little bit about nutrition and hydration. All of us lose some of our sense of taste as we get older. All of us lose some of our sense of thirst. So it's really important that we encourage ourselves, or if you're a caregiver, that you encourage your spouse or your parent to drink, because a lot of us could go all day without drinking, and older people are no exception. You do have to know the dietary restrictions. You don't want to be drinking soda if you have diabetes and need to be watching. You don't want to drink V8 if you have a salt restriction. Coffee doesn't count. You can have coffee, but coffee doesn't count towards hydration, even though it is a liquid. It's a liquid that's caffeinated, and therefore it actually will draw more fluid out of you than it replaces. Just a fun story. When my son was 3, my mother asked for a cup of coffee, and he said to her, "You can have coffee, Safta, but coffee doesn't count," because he'd been listening to me on the phone too much, I guess. When it comes to eating, a lot of us have a decreased appetite as we get older. It's okay to focus on foods that people like. Again, if you have dietary restrictions, you need to work within it. And if your caregiver tells you that you need more protein, you do have to try to find a way to do it. Dietitians can be very helpful. Not all protein has to be chicken or fish. There are other ways to supplement. But it's important to ask your healthcare provider how strict the dietary restrictions are. Not all diabetics have to really, really watch their sugar, to the point that if the only foods they like are foods that are sweetened, that they can't have them some of the time or small amounts. Sometimes when somebody is really more frail and more elderly, we sometimes stop worrying about the sugar at all. So ask the provider. Your mom may have been told when she was in her 70s that she needed to watch her sugar, but if she's in her 90s, the doctor may say that it's just more important for her to get food, or the nurse practitioner, excuse me. So some of the restrictions may not be nearly as strict as they were. That being said, the one that occurs to me that probably is for many people is salt. Salt, if a person has a history of heart failure, can be an immediate threat. So while things like sugar are more of a long-term issue, eating a lot of salt for a patient who does have a history of heart failure can have them in the hospital that night. So again, always ask how many options you have and how much leeway you have. Last but not least, with nutrition, most people eat better if they're eating socially. And again, this is a little bit more towards older, not young old or middle old, but older old adults. They can really start to lose their appetites, especially if they're living alone. And even if you prepare food for them and bring it by, one of the nicest things you could do as a caregiver is stay for the meal when you can. I've seen all my patients who have trouble eating enough. I would say without exceptions, their children tend to tell me that if the child stays for dinner, they do eat better. Okay, socialization and stimulation. And again, this is important for all human beings, but many younger people have it by necessity through work and community activities, et cetera. And as people get older, sometimes their focus gets a little bit narrower. And it's really important to stay social. If you're a caregiver, whatever you can do to help your spouse or your parent, whoever you're responsible for, be as social as possible. There are senior centers and senior groups. The idea of a tablet for FaceTiming, a lot of older patients are really very comfortable with. And it's really nice. They can visit with grandchildren or with friends without leaving the house. And last but not least, not just socialization, but stimulation. I have a patient who just recently, I had a wonderful home PT. If anybody's looking for a wonderful home PT, I can give you her name. But she said to me, the biggest issue with that patient is that her daughter does everything for her. And I never thought about it that way. She said she could fold laundry, she could organize photographs. And then there are things that are just fun, like puzzles. people can be encouraged to stay as stimulated as possible, even if they are living alone. And again, whatever they can do to be with other people is even nicer. Okay. Eyesight and hearing, very, very important. So if you think that your hearing is suffering, again, being stoic can leave you being a little bit isolated, a little bit in your own world. You may not hear what people say, so you may subconsciously stop socializing as much. I would love to say that there are excellent hearing aids out there. The truth is, I'm not sure hearing aids have improved so much since I was a little kid and my grandfather had hearing aids, but they're worth something for a lot of people. And sometimes I'll see a patient and it's as simple as removing a lot of wax from their ears. So it's worth checking and it's worth trying to find out. One clue for me when I do a home visit on a patient is how loud the television or radio is turned up. So you can use that a little bit as an objective measure if the person you're caring for or you yourself have had to raise the volume continuously and now it's up at 50 or whatever. Probably it's a good idea to get your hearing checked. If I walk into the house and I have to talk like this, I do check the person's ears. Same with eyesight. When I trained, there was absolutely nothing that could be done for a very devastating condition called macular degeneration. When I was working first as a nurse practitioner, we had this patient named Dorothea, and she was, oh my God, going to Canada, get these crazy injections, and we'd never heard of such a thing, and we thought that it was insane. And now that's the standard of care, and macular degeneration can be halted. The same with glaucoma, if it's caught before it's done a lot of damage. And obviously everybody is familiar with the concept of cataract surgery. So there are many ways that vision can suffer. And fortunately nowadays, many ways that often vision can be helped. And then there are other things patients use. I actually talk about learning things as I go. I just crossed over when I did a visit to a patient. There was, and I wish I could remember the name, an organization that helps low vision people to adapt their house and their daily activities. So instead of just a regular magnifying glass, they had something a little fancier where you could slide the book in. They had something that could help her sign documents. They had a special light that she could use. So again, even if there's nothing that can actually be done about the eyesight, there are often ways that people can adjust. If that's part of a safety issue, a quality of life issue, a desire to be able to be out, but a fear because of poor vision. Last but not least in this particular category is medicines. Yes, almost all older patients take more medicines than maybe they should. I hear that, I see that, it's on the geriatric boards that I took. I'll be honest, sometimes I go through patients' lists and I'm really not clear what we could take away. The patient has blood pressure and we need these meds to control it, and then they were complaining of heartburn. So often we do need meds. That being said, there's nothing wrong with asking your healthcare provider on a regular basis to go through your meds and make sure that you still need everything you're taking. I am going to say though, and I don't mean to sound, silly, medicines don't help if you don't put them in your mouth. So I have a lot of patients who give them a medicine and they tell me it works or it doesn't work. But then it turns out that they're not taking it regularly. Or they took it for 2 days and then they stopped because they didn't think it was working. Be upfront with your healthcare provider. If you're not taking something, that's fine, but let them know, because otherwise we're trying to figure out the best regimen for you, and it would help us to know what you're taking and what you're not taking. Please keep an updated list. I have been seeing patients for 18 years now, and I would say about 50% of the time, the people pull out the list and then say, oh, wait, except this is only once a day. And that was switched, and I don't take that anymore at all. If you could, when you come home from a visit with a specialist or with your primary, update your list, so that if you have to pull it out and you don't remember everything, you have it written there from when it was actually changed. It's important because if I lower somebody's blood pressure medicine, but they don't write it on their list, and then they end up in the emergency room may give them the higher dose because they think that's what they take. So sometimes that can really be life-saving to have your list be correct. If you are a caregiver for an older patient, or if you're a patient who does not have perfect memory, so really, I mean, all of us, I'm a huge, huge fan of the medicine box. Leaving out your bottles and saying you're going to take one of each every morning and one of this one every night is fine until it's not, and you can't remember if you took it. And then you try to decide whether it's better to take two or maybe not to have taken it at all. It's a lot of unnecessary anguish that really can be prevented by filling a medicine box once a week. And that way you look at Tuesday night and you go, oh, I forgot to take it, and you take it. Once in a while, even I forget what day it is, and I've made mistakes that way, but most of the time I remember what day it is, and having a medicine box is very, very helpful. For people with memory issues or attentional issues, again, something I learned from a patient's daughter is that there are medicine boxes that actually flash, like a light will flash until they open that day and take the medicine and close it. There's some that do beeping. And this can be really, really useful for somebody that tends to forget to take their medicines. Shabbos issues I'm not addressing here. You know, if that becomes something that you would need, ask your rabbi. But I found that incredibly useful, and it actually kept a couple of my patients home longer than I might have thought, because the main reason we were worried about them living home alone was taking their meds correctly. And once they had this flashing or beeping reminder, they did a better job. One more thing I'm just going to mention is, well, I sort of alluded to this, but if you're not taking your medicine and you're not taking your medicine, but you don't tell me or your other healthcare provider that you're not taking your medicine, I may be raising doses of things. And then if one day you suddenly decide to take your medicine, it could drop your sugars, it could drop your blood pressures. So please, please, I'm not judging you. I don't think other healthcare providers are judging you. The main thing is that we know what we're working with. When I was just a student, not just a student, students are important, but when I was a student, I was going with a preceptor to a patient's home. And on the way, she was racking her brains. You know, I already have her on this medicine for sugar. I already have her on that medicine for sugar. I don't know what else I'm going to give her. Her sugars are out of control. And we get there, and I don't know what made my preceptor suddenly say this, but she said to the patient, Martha, where are your medicines? And these medicines that Martha had insisted she was taking every single day, she couldn't find. So that was a hint that maybe she wasn't taking them. And then to keep raising doses or adding medicines, if suddenly Martha decides to take everything, could really be dangerous for her. So again, if you're not taking something, that's okay. People sometimes forget. They forget to refill something, and then they really forget. And now they're just not taking their cholesterol pill at all. There's no shame in this. You know, we all have a lot going on, but try to be careful that you are taking what you're supposed to be taking, and that if you're not, you're upfront about it. So that's kind of my general healthy aging, chronic conditions, etc. Then I was asked to comment on advocating for yourself and for loved ones. So I just want to mention that I'm specifically not addressing, and it's a little bit counterintuitive, I'm really not addressing right here taking care of patients with dementia or being a patient with dementia. Dementia affects an enormous part of the population, but the issues there get so complicated and really need to be so individualized to the stage, to the caregiver's capabilities. So I'm just kind of not discussing that. If anybody has a specific question during the Q&A, I'm happy to try to answer. But everything I'm talking about here about advocating for yourself, advocating for the person you're taking care of is really for people who can share information back and forth and who are, generally reliable historians, etc. So first of all, if you're a caregiver, and a lot of the people I see tonight are not, they're much younger than I was anticipating, and they take care of themselves beautifully. But if you are a caregiver, I'm just going to say, in case anybody needs to hear this, and sometimes you need to hear it from an authority figure-ish, accept help. When people offer to help you, say, yes, that would be great. Thank you so much. You can set some boundaries. You can have things that you can't do, even if it's your mom. You can have things that you're just not able to make time for. And it's okay. It's important to take care of yourself also if you're a caregiver. So you need to make sure you're not skipping your own doctor's appointments, your own time for activity and physical activity and exercise, that you're also eating well. You need to make sure that your goals are reasonable. And it is not a reasonable goal to do everything for an older parent all the time, 24/7. That's just not a reasonable goal. So again, if what I'm saying rings a bell to you, please copy it down and read it to yourself every day. I try to tell caregivers, main thing is safety. If your parent is safe, most important job is done. So you can sit down for a minute. And then of course, we want the person to be in good health to whatever extent we can. And then of course, we would love good quality of life. But remember that it's a little bit of a hierarchy. And if there's a day when really the most that you can assure is that the person you're caring for is safe, there are going to be times and days when that's what you can do. And you need to just be okay with that. If you feel that you're not able to care for them in the way that you'd like, then that needs to be addressed, either with the healthcare provider or with other people that might be responsible for the same person. I don't mean that anybody should feel like they are neglecting the person that they feel they are caring for. I just mean that if there has to be a period of time when the person is safe, but maybe not happy at that moment, these things happen. And please, please don't beat yourself up. Both patients and caregivers, I want to stress that when you see a healthcare provider, it is okay to express preferences. I would ask that you not say it in a super confrontational manner, but it's really okay if the healthcare provider starts to say, well, I think in this case, I would start an antibiotic. It's okay to say, I'd really love to avoid an antibiotic if I could. How long do you think I could safely do that? Or do you think there's a way I could safely do that? Things are not written in stone just because we say so. I don't always know whether a patient is looking for the more aggressive or the less aggressive approach. And often there's a lot of leeway between them. There is rarely a situation, they do come up, but there are rarely situations where this is what you have to do. There is no other option I can think of, and I can't think of another way to give you a safe and healthy option. Often there's, as I said, a more aggressive, should I see a cardiologist? You could see a cardiologist. If it would make you feel more comfortable to see a cardiologist, of course you can see a cardiologist. But if you're asking, do I have to see a cardiologist? At my age and my status of health, I sort of feel like I'd rather not be seeing multiple providers. That's a different question. So if you phrase it very open-endedly, should I be seeing a cardiologist? Is it something you're looking to do, or is it something you're trying to gauge whether I think it's necessary, but I forgot about it? You can speak up. It's okay to express preferences. I'm going to say, here's something that's very important. It's not okay, it's important. Please, please tell the healthcare provider if their plan A did not work. Because almost anything that we recommend to you is plan A. It's very seldom that there's only one solution for a potential problem or only one possible diagnosis. So often we say, that looks like a nummular eczema. So here is a steroid cream. But then we usually say, and we mean it, if that's not working, please let me know. Because if it's not working, that might be a clue. It might tell me that it's actually a fungal rash and I should be treating it with something else because the steroid didn't help. Sometimes it's not that it's a clue, it's just that, okay, that doesn't work for everybody, but I have a plan B. So please give your healthcare provider the chance to fully take care of you. And if you see that something that your provider didn't solve the problem fully or didn't solve it at all, I think the nicest thing you could do, well, that's really separate. Whether you're nice or not is not your problem. I think the safest thing you could do for yourselves is to bring it up to the original provider and say, that really didn't work. What should I do now? Now, obviously, if your provider answers by saying, of course it should have worked, something's wrong with you, well, then that's not appropriate and you should see somebody else. But overall, it's very frustrating, I know to me, and I'm sure to other people, when somebody says, yeah, the cream you gave me didn't work. So I went to, another doctor and they gave me a different cream. So I was going to see if that worked. Again, I'm not saying that you don't have the right to see another doctor. Of course you do. But if you call your provider and say, I'm not tolerating this medication, or the medication doesn't seem to be working, really, really often they have another idea that could work better for you. And I do recommend that. So I think that's very important, is to tell them if something fails. Totally amazing, as I said at the very beginning, to discuss with your peers their healthcare. If they mention something amazing that their healthcare provider told them, sharing information is awesome, and people learn a tremendous amount. I am going to beg people on bended knee to then tell their healthcare provider about it. Because if you do something because your neighbor Gladys was doing it, sometimes it's not safe for you, even though it was safe for Gladys. Sometimes Gladys had the wrong information and she thought she was being treated for this, which you have, but she wasn't. She was being treated for something else. There can be missing information or there can be outright misinformation. My favorite story about that is a woman who stopped taking her metformin, which is a medication for diabetes. It was controlling her diabetes beautifully. And when she came in for her visit, her diabetes was completely not controlled. And I said, oh, are you taking your metformin? No, I stopped my metformin. And I said, really, why'd you stop your metformin? Were you having stomach issues? Because that does happen. And she said, no, but my friend told me that it was a gateway drug that leads to heroin use. Okay, well, clearly somebody had some missing or misinformation. I'm guessing it was, they didn't hear that it was marijuana. I don't know. I'm not saying marijuana is a gateway drug. I'm just saying. So again, it's fine to learn stuff from your friends and your neighbors and the guy who sits next to you in shul who's a neurologist. But speak to your healthcare provider about things you learn or want to implement. Often we'll say, sure, that's fine. That vitamin is great. I can't tell you if it'll work, but no problem. And occasionally we'll say, actually, that can cause bleeding. And, you already take a medicine that can cause bleeding. So I believe this was about taking a full teaspoon of cinnamon, which apparently can lower blood sugar, but apparently can also cause bleeding. So people who are taking blood thinners maybe shouldn't be taking a full teaspoon of cinnamon, even if somebody told them that it was a nice, healthy thing to do. Important, if you get care from somebody else, to tell your healthcare provider that too. Let's assume the healthcare provider who treated you, the dermatologist, the cardiologist, whoever it is, gave you good advice. It's still important for your primary to hear that you're taking something new or that you're taking, a new supplement. Sometimes I had a patient who was given an antibiotic by a qualified doctor, but never told me that she'd taken it. It happened on a weekend, and it was her son, who's a qualified doctor, and he put her on a medication. And when I saw her next for her routine checkup, one of her labs was completely out of whack. And I said, did you do anything new? And she said no. So I sent her to a renal specialist because I was like, well, this is concerning. And then it turned out, way later, after she'd gone through a whole renal workup, that he'd given her an antibiotic that can cause a transient elevation of this particular lab value. So if she'd come in and said, my son gave me this antibiotic over the weekend, I would have not have, or when I said, did you change anything? Did you do anything different? That would have been a good time. So I know it's a lot to ask, but try to keep track, because it's a lot for us to try to keep track of also. So the more information we have, the better we can keep people safe, but also healthy and also good quality of life in that same hierarchy. Last but not least, if you are a caregiver and you take someone you love to the doctor, let them talk if they can. Let them answer questions if they can. Make sure that the healthcare provider is talking to them if they are aware. On the flip side, please do not take them to the doctor and then sit in the exam room, but be on your phone the whole time without once making eye contact. That makes me nervous as a provider, and probably other providers too, if I had to guess, that something could get missed. You know, if you felt that you should be in the room, it would be really good if you were also focused on the visit, because you might miss an opportunity to make a very major correction. So just saying, it's a little bit of a pet peeve of mine, is people who come in with the patient, but then are scrolling on their phone the whole time and they literally don't look up. Okay, I'm basically done with my information. I do just want to say that aging is not easy. Caregiving for people who are aging is not easy ever, no matter how good the relationship and how nice all the people are. Please know that I do feel for any caregivers that are listening. I think there's a very special place in heaven for caregivers. Again, it's never easy. I think it can be very rewarding, sometimes not at all. It's very, very important. I always wanted to work with older people. And I think, you know, you could say I found them interesting, I found them fascinating. I was the only graduate from my nursing school of 110 who wanted to work in a nursing home. It was very unusual. I think it was more an innate sense that older people deserve good care, and they become a vulnerable population where it's a little harder for them to stand up for themselves, speak for themselves, and run around to access the best healthcare. So I believe very strongly that as people age, their healthcare needs go up, but that doesn't mean that their deserving of good healthcare goes down. Remember, if you're a caregiver or a person who is getting older, that your healthcare provider is a part of the team, and not just to diagnose a sinus infection or your blood pressure, but if you have issues that are coming up that you think are related to aging, bring them up. We can't fix everything. We can't solve everything. But we can sometimes connect you with resources or with suggestions that you might not otherwise have known. And I think that's the end of what I have to say.
Thank you so much, Miriam, for all this information. I think I saw everyone writing their notes as well as myself. I work with older adults and seniors, and I'm always looking for just more information and how I can better help my clients. So I'm very grateful for this. And now we are open for questions from the group. So I see Sheila Broad over here, asking her to unmute. Okay.
Yeah. Hi, Miriam. I enjoyed what you said.
Thank you.
A caregiver for my mother. I wanted to know, how do you handle situation where patient, say, is mild cognitively impaired and refuses, say, wound care or medications?
As I said, once people are cognitively impaired, it's really, really challenging. And I'm sorry for what you're going through, or if it was a theoretical question. I don't know that there's any one answer. I think that's a situation where you would do best with somebody who knows the patient a little better. I've sometimes slid things in by telling somebody that we just have to do it temporarily. You know, we're just going to do it for a few days to see if they'll accept that. With people with cognitive impairment, I would never say we lie, but sometimes we embellish a little, or we'll say, you know, we just need to keep it clean. We're not doing anything else. But that is a hard one. I'm happy at some point to discuss it with you further, but yeah, once there are cognitive issues, everything gets hard.
Okay.
Naomi Greenberg, hand is up.
Yeah, I have a question. So I'm also a caregiver of my mother who's elderly, and her eyesight is getting worse. And she has a bunch of eye drops that she's supposed to be putting in her eyes, and we have no way of knowing if she's getting them in or not. But they come in these tiny little bottles that elderly people, and even for myself, getting these tiny little drops, you need a lot of dexterity. Does anybody like you or anybody know of an easier way to make sure that an older person could get the drops in? Are there any
Hacks for eye drops?
these eye drops are these tiny little bottles that are really
They
hard
are.
to push and get them in. For older people, it's extremely difficult.
It is. One thing that I learned from an eye doctor is that you don't need to worry about overdosing. So if the person isn't sure that the drop went in, they really should just do another drop.
Right.
Because apparently the conjunctival sac can only hold about one drop. So if you already put the drop in, then the second drop will just roll out. Nothing off the top of my head occurs to me. I know when my patients are going for cataract procedures, they need to be using drops. They often have to have a daughter or a sibling be coming by to help them. Drops are tough. I'm
Okay.
sorry. I feel like I'm not helping anybody tonight.
It's okay. I'm just trying to do my best to see if there
No,
is
it's a
anything.
very good question. I would say actually it brings up a good point. It's very, very hard to know for sure if patients are taking any medicines or using drops or using inhalers. At a certain point, as I said, if you're the caregiver, all you could do is your best. Like really, really, all you can do is your best. I tell people to look at the med box, and sometimes I'll tell them to count the pills if we're really concerned, but at a certain point, if the person is cognitively okay, and this goes back to Mrs. Broad's question, if the person's not cognitively okay, then you really are, out at sea. But if the person is cognitively okay and they think they did the drops and they think they felt the drop go in, at a certain point, I probably would just leave it there. But you're right, it's not easy, and we do sometimes just suspect that somebody isn't getting their drops or isn't getting their meds or isn't taking their inhaler correctly.
We need to get the
Sometimes I do
pharmacies to make
discuss with caregivers that sometimes you don't want to trade accuracy or efficacy for dignity. So if somebody is, and this goes to Mrs. Broad as well, mildly cognitively impaired or cognitively fine, but 90, there are some times that I will, and it's on my head, I will counsel the caregiver, the child, whoever, look, at a certain point, I'd rather that they have their dignity. And if they say they're taking their meds, I don't want to be there and trying to show them up and say you're not. Again, as I said to Mrs. Broad, these are a little individualized. So I certainly would never say all patients should have dignity, and if they say they're taking their meds, don't even look further. But sometimes you do get to the point where you say, I'd rather that they still feel like they're in control and not constantly be checking up on them. That being said, I've been known to take surreptitious looks at my patients' medicine boxes if I'm at their home. One fabulous patient named Rose had color coordinated her pills so that all the blues were together and all the greens were together and all the reds were together. And that was very, very bad. So if you notice something of that, that's a huge, big problem. But assuming that mostly the med box appears normal or mostly they seem to be refilling on time, there is a point where I sort of say, all right, we're doing what we can. But again, a lot of this is judgment calls.
Jerry, you have your hand up.
Yeah, can you hear me?
You're a little low.
Hold on. Let's see if I can get closer. I take a lot of meds, about 20 different meds and injections for multiple problems, unfortunately. And I'm wondering, the interactions, you're trusting the pharmacist and the doctor, and you're thinking, well, I'm just diluting my body with so much different medicines and stuff, and the toxicology and stuff. And I'm saying, how much is enough? Like, I just feel like if you cut your veins, you're gonna bleed out medicine. You know, and I just feel like I'm on way too much. I'm gonna have surgery soon, hopefully, and maybe get rid of some of them. But still, you know, I just feel like, is there a danger in just taking way too much? You know, even though the doctors all prescribe it, multiple doctors, and they all want to know your med list, and of course the pharmacy knows. And I just think there's got to be interactions. I do have side effects.
There are always interactions, and there are usually side effects to at least some things. I do try to remind people, and again, this is not individualized to you, but I do try to remind people that the diseases that we're trying to prevent or manage have their own side effects. So somebody may not want to take 3 different blood pressure pills, but if that's what it's taking to get their blood pressure down, remember that a side effect, air quotes, of high blood pressure is a stroke. So, you know, the stroke has terrible side effects on its own. It's a hard question. And again, as the primary care, I really consider myself kind of the gatekeeper for all the meds. So this is why, as I said, in a perfect world, a patient called me once, patient named Irma, and she had horrible back pain. And she called and said, I went to the orthopedist and he gave me XYZ. And I said, please don't take that. It interacts badly with one of your anticoagulants. Okay. And he also gave me ABC. And I said, please don't take that either, at least not at that dose. That's a very huge dose for an 85-year-old. And again, this is part of why a primary care can be valuable, because an orthopedist may not be treating a 70-year-old or an 80-year-old any differently than they treat the 30-year-old or the 40-year-old, and may not, even if they look at your list, they're not the ones that have to deal with the fallout. So this is an argument I have with cardiologists all the time. They want everybody's blood pressure so low that the people are practically dead. And I'm the one who has to answer the calls when they say they're dizzy and they feel fatigued because their blood pressure is so low. So I would say my recommendation would be to take to your primary care and just say, could you look at my list, double check for me that we think that all of these are necessary. And if we do, because otherwise we have uncontrolled diabetes, uncontrolled hypertension, uncontrolled vascular diseases. I mean, things can be really serious, and the medicines in 1,000 ways save lives. But in the event that all of them are necessary, are they interacting okay? Are there ones I should think about substituting? You know, yes, we do get, not just the pharmacist, when I call in a new prescription, I'm given an alert. If, you know, my system is halfway good, that tells me, you know, this contiguous with the other medicine this patient takes together can cause a heart arrhythmia. And I go, oh, whoops, I forgot that. And I go back and try to order something different. So there are several stages where both the provider, whether that provider is the actual prescriber or not, and then the pharmacy, you know, between all of them, us, things are supposed to be caught. Are they always? No. And again, this goes back a little bit to advocating for yourself. It's okay to ask. Just because the healthcare provider doesn't think to do something, it's okay to ask that. Let's say it's your physical and you feel like, well, I guess if the doctor thought it was important, he would have brought it up. It's okay to say, could we just go over my meds? I just want to make sure I'm not over medicating myself. The other thing that happens is sometimes when you're 60, you need more medicine for sugar and blood pressure, et cetera. I have seen patients who just don't need quite the same quantity at older ages. And if nobody takes the time to sort of look at the doses and see whether they're really necessary. I mean, I've had patients come to me and it's just because, it's not because I'm better, it's because I'm taking a fresh look. So I'll have somebody come to me who just moved down from Boston and she'll say that she takes this and this dose of a water pill. And I'll say, oh, that's really kind of a high dose for somebody your age. Could we try a smaller dose? And, oh yeah, but I've been on it for 30 years. Sometimes that's exactly why trying a smaller dose is a very good idea, because they've been on it for 30 years and their body has certainly changed in 30 years. So never hesitate to speak up. I'll be honest, if a healthcare provider gets insulted because you ask them to do something that they did not suggest doing, that's not that's not your fault. That's not your problem. And, you know, we can all have a bad day and react badly, but if that's typically how a healthcare provider reacts, I don't think you're going to think of them as so accessible. So I don't know whether you're going to feel like you're getting the best care if you don't feel free to bring something up with them.
Yeah,
Did that sort of answer your
found-
question?
No, it does a lot. Thank you. And I did do that once with something that I'm not severe diabetic, and I was taking a health med that raises sugar, so they don't always catch it. And I said, wait a
Correct.
second. And the different one, I don't see that provider. Another one that specializes in the same field switch me to something else that doesn't have that side effect. So they don't always catch. You have to be a on guard yourself because they don't always catch these things.
The other thing I will say, though, as a devil's advocate, is there are times where if you read the stuff you'll see on the internet, and I'm not knocking the internet, I use the internet also, you have to know where to look, but like I've had people say to me, can you believe this doctor put me on this and I have that condition? And I'll say, actually, we do that all the time. It's very common. But no, it says that it could raise my this if I take that. There are many interactions that affect so few people and do so much good for so many more. And the interactions are so rare and so mild that we do go ahead because they're easier or cheaper. So, you know, I had one patient say to me, I can't believe it. My previous doctor said I could take Advil, but I have high blood pressure. And I would say, you know, you can take certain doses for short terms, you know, well, it says it could raise blood pressure. You know, we don't generally see that it raises it so badly if used for a few days for a particular condition at a particular dose. Again, if you have people in the audience who are blood pressure specialists and you disagree with me, I apologize. But I will say in primary care, we pretty freely will give even patients with hypertension, which is a large number of my patients, Advil for short-term things when we feel that the anti-inflammatory effect of Advil outweighs the potential problem. So just because it says somewhere that this medicine could raise your blood sugar, I have often made the conscious decision to use it anyway, feeling that the benefits likely outweigh the possible risks. So just be aware that honestly, everything interacts with everything at this point, and I wouldn't be able to use any two medicines if I was not willing to risk any interactions.
Okay.
Can I ask a question?
Yes.
Is anybody hearing me?
I hear you. What's your name?
My name is Judy. Judy.
Oh, Judy. Sure.
Yeah, it's me. Yeah.
Hi.
Okay. Hi. I guess my question has to do with the etiquette of self-advocating. I feel like I've been living through hell for the last year, you know, with my doctors in terms of not being able to access them, you know, like putting in a call because I have a question about something. Some of them don't call back. Some of them take a month to call back. Some of them take a week to call back. And generally, if I've called, it's because I'm concerned about something, you know, and, you know, I don't want to be a nudge, you know, it's like how often can I say, you know, I need to speak. I feel like I'm in this position a lot. I feel like I've caught a lot of mistakes, you know, like the wrong discharge instructions when I've had an angiogram, you know, a lot of little things like that, sending me the wrong person's history. And I'm nervous if I don't really understand what a situation is. And I find that doctors these days don't like to spend a lot of time explaining it all. So like I find myself, I'm always measuring, can I call yet? Is it, you know, is this being a pest? Is that, you know, is that too much? Is there like an etiquette involved in it? You know,
Very good question. I'm actually going to say that I think you're asking two different questions. One is, well, you address the fact that you've been catching a lot of mistakes, and then you're also asking about, you know, when you do have questions, what's the etiquette? So I'm just going to say first to the thing about catching mistakes. I wish I didn't have to say this. nobody can just relax and just be a patient anymore. I would love to say that you can. I was in the hospital a couple of years ago. I had a procedure to put a pacemaker in. I was so excited to just be the patient and not ask questions and not ask what medicines they were giving me and just lie there and let them take care of me. But I couldn't because I'm a nervous person. And I said, "Oh, what medicine are you giving me?" And they announced that they were giving me the wrong dose of the wrong medicine. You can't, I would love to tell you that you can relax. And unfortunately, you're right. I could blame insurance and Medicare reimbursement. I could blame, there's a million things to blame. But the fact is that many healthcare providers feel very squeezed, and they only have X number of minutes, and they have a pile of work that they need to get to, and they're going to make mistakes. And that's nurses in the hospital, and it's doctors in the hospital, and it's nurses and doctors in your doctor's office. And I'm going to say freely, I've made mistakes. I try very hard not to because of that nervous nature. But even I have made mistakes, and I really, really try not to. And I'm very blessed that I'm not pushed to see, a million patients a day. So you do have to be careful, and I wish there was a way around that, but you do have to read your discharge papers, and you do have to ask questions. This looks like a new med. I don't think I was on that. Is that new? Is that being added, or was that a mistake? You do have to ask. And on that, you do not worry about being rude. If somebody thinks you just ask nicely. You don't have to ask in a very confrontational or hostile manner. But if you say, "Oh, I don't recognize that medicine. That's on my discharge paper. Is that new for me? Or is that maybe a mistake?" It's always not just okay. It's important for you. And you do need to know that in the end, nobody cares more about your health than you do. Really, not even me. And I care a whole lot about my patients. Nobody cares as much about you staying healthy and well as you do. So do always double check, unfortunately. Then your second question about the etiquette, it's a hard one for me to answer because I'm so appalled by the idea of a doctor taking you a month to call you back. So I would say, I don't know if that's one doctor who's consistently taking forever, or if you mean that every doctor you've tried to reach for different reasons is taking that long to call you back.
Yeah. I'm thinking of two right now, but yes, there's one doctor in particular. He's very nice when you see him, but somehow you leave a message and nothing happens, and then you leave another message a couple of days later and they say, "No, we didn't even have your message." Somewhere between the doctor's schedule and the office staff's schedule.
Yeah. And office staffs are not perfect either. There's no question. I love my office staff, but they've made mistakes too occasionally.
I recently had them decide that they're not going to do a valve replacement that they were planning to do for a long time. And they said, "We'll call you when we're ready." And then I didn't hear from anybody for at least for a month. So
look, I would say on something like that, things really can delay procedures, et cetera. And I have had situations where I really don't have any more information to give for a month.
Right.
I would say in general, what I do recommend to people before they choose to leave a doctor because of what they feel is a lack of responsiveness, I figure if you're going to leave them anyway, maybe first address it with them. So I've suggested that people say to a specialist or to whoever, I've noticed that the last couple times I called, it took a very long time to get a call back, or I didn't get a call back until I called several more times. Is there a better way to reach you? Because this is very difficult for me. Yeah. And how they answer will really give you an idea. If they go, "Oh my God," which is what I would say, "Oh my God, you took a month to get a call back from me. I've never heard of such a thing." Yeah. I'll have to address that immediately. As opposed to the doctor going, "I don't know what to say. We're busy and everybody's busy." To not hear back from somebody same day, often doctors will be right up front with you and they'll say, "Please don't expect to get a call. I only call back within 24 hours. So you might get a call tomorrow." Mm-hmm. To say that you're not going to get a call for a week. And again, depends a little bit what you're calling about. If it's something more urgent, less urgent. But I think it's always appropriate to say to the provider themselves, or you can ask to speak to a manager of the office, "I just want to know, is there a better way to reach the professional? Because here was my experience." And if they sound like they don't care, I'm sad to say that I would probably just look for somebody else. But if they say, we're very sorry, and, you know, we'll really try to make sure that doesn't happen again, or here is the number of the manager, and if after one call you haven't heard back a day later, please call the manager directly. You know, some offices really want to do a great job. And maybe they even used to 10 years ago, but now they're being asked to see twice as many patients with half as many staff. And it might be that they're having trouble keeping up.
Yeah, okay. Okay, thank you. Yeah.
Does anyone else have one more question? It's 9 o'clock. If anyone else has another question. I have one, if I could just ask one question.
Sure.
What do we do about falls? Is there any tips that you can, like, fall prevention?
So some of the ones that we're all taught in school, you know, no little rugs and be careful with animals. But I think most people sort of already know that. It never hurts to double check. You are correct. Falls are devastating. Falls are a catastrophe.
Yeah.
The best thing I can tell you, if I had to pick one thing, is PT. When my patient has a near fall or a fall, I push PT because being stronger and better balanced can never hurt anybody. After that, it's a little bit of an issue of, you know, why are they falling? I have patients who fall because they refuse to use a cane or a walker. It's probably not going to be a whole lot I can do if they'll still refuse to do that. But sometimes if they're also wearing slippery socks, we can get them to wear socks with little rubbery things, or, you know, wear their sneakers at home, and they fall less. I don't know that it's possible to really prevent all falls. And this is something that I know my caregiver to patients really have a hard time with. Even if your loved one has 24-hour supervision, they still can fall.
Yeah.
Supervision obviously helps because you can scream out to your mom before she stands on the rickety ladder to change the light bulb. And yes, that's a true story. But in general, sometimes falls are going to happen. That's probably the best example of when I tell patients, caregivers, remember to leave them their dignity. So doing everything for them to prevent the falls is almost never a good idea, and not letting them do some of the stuff that they want to do does rob them at a certain point of their dignity and is paternalistic, which is not what we want either. Patronizing is probably what I meant to say. So it's hard.
Yeah.
And you're right. And I do try to scare people with, like, we don't want you to fall. So let's do the PT. You know, we don't want you to fall and hit your head. Falls are devastating, but I would say other than PT and good assistive devices, and then again, no little rugs, good lighting. Some of my patients seem to live in caves, and I'm like, turn on all the lights in all the rooms you're going to be in today, and then turn them off at the end of the day. All those things can go a long way towards helping. And obviously that's assuming we don't have underlying medical conditions. Like I said, if their blood pressure is being overtreated, they may fall because their blood pressure drops when they stand up. So if the person is falling a lot, it's a good idea for them to bring it up with the healthcare provider. I just had a patient who just went into the hospital with a fall, and it turned out she had COVID. You know, she was not a faller, and we were all so surprised, but she had COVID. She was weak. She didn't realize she was sick, and she fell.
Okay. Okay. Thank you. Thank you.
Thank you all. I appreciate everybody's time and attention. And if I helped one person with one tip, I am delighted.
Yes, thank you.
Thank you so much.
Take care. Everybody have a good night.
Thank you, everyone, for joining.
Thank you.
Have a
Bye-bye.
good night.
You too. I don't know how to get out. I don't know how to get out.